Hello, everyone. Thank you for joining us, Granite Peak, for our presentation today. We have a guest presenter, and that is Betty Bajarias. She is a registered dietitian who's been in the field for quite a few years, an expert in the area, and she's going to present on F692 nutrition hydration status. And so we'll ask that you put your questions in the chat, or you can hold questions. And if we don't have enough time with the presentation, you can certainly email one of us and we'll get back to you if you guys have any questions. With that, I will turn things over to our expert, Betty. Thank you, Betty.
Yes, hi, Carmen. Thank you so much for the introduction, and good afternoon, everyone. I hope everybody's having a great day. Now, this is an overview of F692, nutrition and hydration. This is only a 30-minute presentation. So as Carmen mentioned, if there are any questions that we're not able to get to after this presentation, we'll be more than happy to answer them if you would just email those to Carmen. So with that being said, let me get to, okay. So the objectives for today's presentation are, so we're gonna go over the definitions of 692, the difference between weight loss planned versus unplanned, why is a weight loss concern? And then we're also going to go over potential causes of weight loss, the assessment portion, care planning, interventions, monitoring, survey prep, the investigative protocol, and then the key elements of non-compliance. So again, as you can see, this is a pretty lengthy objectives, but each section is just going to be an overview. So we'll start with the definitions. Most of you, if not all, are familiar with the F692 tag, nutrition and hydration, status maintenance. So in this tag, what we have to meet is or prove is that the resident maintains acceptable parameters of nutritional status, such as the usual body weight or desirable body weight range. Now, oftentimes, those of you that are either completing a nutrition assessment or entering information regarding weight, I still see quite a bit of facilities using ideal body weight versus usual or desirable body weight range. Ideal body weight really should not be used. The next thing that we must prove under this tag is that the electrolyte balance is normal unless the resident's clinical condition demonstrate that it is not possible. Additionally, we must offer residents sufficient fluids to maintain proper hydration and health. Now, I see many citation under this tag stem from insufficient fluid intake because, we are focused on providing fluids at meal times, but we are forgetting the in-between. So just kind of keep that in mind. That's where we'll usually see this cited. And then the last here is that the residents is offered therapeutic diet when there is a nutritional problem and the healthcare provider orders a therapeutic diet. Now, the intent of this requirement is that the resident maintains to the highest possible acceptable parameters of nutritional and hydration status, and that the facility provides nutritional and hydration care and services to each resident. So that means all residents. Identifies and assess and address the nutrition and hydration needs of every resident, and provides therapeutic diet to meet the resident's condition and preferences as the need arise. So this does not only impact residents that are on PO, this will also impact residents that are on enteral fees. Okay, now that we've established the guidelines and expectations of F692, for today, we're mainly going to focus on weight loss. So first, let's define planned versus unplanned weight loss. So planned weight loss is prescribed by the resident's physician and care plan with a weight goal. So an example of this would be, let's take a 300-pound obese 45-year-old female who is being prepped for knee surgery in 3 months. The physician, oops, sorry, what happened? The physician may order an RD consult for weight loss regimen. So this would be an unplanned weight loss. Plan. So then an unplanned weight loss is unintended weight loss resulting in 5 or more loss in 1 month, 5%, 7.5% or more in 3 months, and 10% or more in 6 months. So an example of this, let's take a 120-pound underweight 70-year-old female with good intake who continues to lose weight unintentionally. So that would be unplanned because that was not prescribed planned weight loss. And there's actually a third definition which this is probably the most commonly overlooked when we are reviewing the weights, whether that's weekly, monthly, etc. So insidious, that is when a gradual, unintended, progressive weight loss over time. So a few examples here, 2 to 3% loss times week over week, or perhaps 3 pounds lost month over month. And not necessarily that this will trigger on your monthly weight report. And again, oftentimes this might be overlooked. So an example of an insidious weight loss would be, let's take a resident that is 85-year-old female, 100 pounds, who continues to lose 1 to 2 pounds per month. Now, that is not significant enough to trigger a 5% in 1 month. And so to me, this is really where we need to pay a lot of attention, or the insidious weight loss, because this can essentially, if you identify this early enough, this can prevent significant weight loss, which is what we're trying to prevent to begin with. So why is weight loss a concern? Evidence shows that there is a strong correlation between weight loss and morbidity or mortality. The higher, and from what I've read, the higher rate of death, or there's a higher rate of death in the 6 months following a weight loss of 10%. And even worse than that data shows, death was 4 times more likely within a year if residents lost greater than 5% of weight in a month. So this is why weight loss is a huge concern, and that we all need to put a lot of attention to this. Additionally, weight loss may reflect loss of muscle, which ultimately contributes to weakness, loss of independence, falls, etc. And we all see this in our centers. It could also increase risk of infection or decrease immunocompetence. Additionally, in an Alzheimer's disease resident, weight loss is associated with disease progression and may be predictive of mortality, and also could potentially be an early sign of dehydration. So collectively, all of the above consequently may contribute to the unplanned hospital discharges, which we are all trying to prevent. So the big question here is, who is responsible for weights in your facility? Anybody want to share? Is it your dietary manager? Is it your unit managers? Is it the nursing staff? Is it social services? Is it your RD? Anyone?
I can see Billy said it was the rehab restorative staff. And honestly, I need to add to that, Billy, because when I was a director of nursing as well, that's exactly what we did. We had our restorative team take on that piece because it was the same consistent people who were aware of the need for the consistent weights and how you take the weights and that kind of stuff. So I'm not sure if anybody else has anything different, but we did the same thing.
Awesome. Thank you for that, Billy. Appreciate it. Now, guys, I'm not seeing you in my screen right now, so feel free to speak up, or Carmen will continue to monitor the chat box. Thanks, Carmen. Okay, so ultimately it's everyone's responsibility. So not just the dietitian, not just the dietary manager, not just your restorative, it's everyone, because the weights is weights, but if you look at the weight system in its entirety, it has so many different components. So really, if we're going to assess weights correctly, it really starts with nursing obtaining and accurately documenting weight per facility's protocol. And let me, did I skip? No, okay, sorry. Making sure I didn't skip. And yes, IDT needs to be involved. The physician needs to be involved. At the very least, they need to be notified, and we need to document that. The family could be a viable key player as well. And then also don't forget the resident. If they're alert oriented and able to participate in their plan of care, we definitely need to make sure they're involved as well. Now, potential causes of weight loss. Let me just back up here a little bit. So who on this call agrees that the primary cause of weight loss is due to poor appetite or poor intake? Billy, thanks, Billy. At times, yes. Okay, no, I like your answer. Anybody else? That's a great answer. So, okay, so oftentimes when I'm reviewing medical records, chart reviews, I see often consult for the RD because the resident is not eating well, or there's poor intake, or there's a weight loss. And then often the intervention is immediately additional calories, protein, whether that's via food or ONS, oral nutritional supplements. So we've got to, and I know surveyors are now looking into root cause and documenting that. And we're not just regurgitating what the report says. Jacqueline Smith showed a significant weight loss of 5% times 1 month due to poor intake. Therefore, add oral nutrition supplement, BID, for 30 days. Okay, where's the root cause, in that? So we haven't really done a good job of digging. So I provided, and these are just a few. I mean, I could probably add 50 more to this list. But again, this call is only 30 minutes, so I wanted to keep it brief. But potential causes of weight loss that the IDT need to consider. There's a few here. One is acute illness. Was there a UTI? Was there a URI? Was the resident anxious? Does the resident have broken or missing teeth or chewing problem? When was the last time we considered COPD that might impede in their appetite or just total intake? Depression, possibly. Dry mouth. How often do we see some residents with poor oral care? How about family visitation? Frequent infection, perhaps, maybe an ill-fitting dentures. Like I often see that social services will write in their notes that the resident was either missing their dentures or it doesn't fit right, it's creating sores, but then nowhere does that mention in the nutrition assessment portion that that could be the potential cause for the resident not eating well. So then, would increasing food and ONS be an appropriate intervention, or would it be more like, okay, we'll need to work with the dentist or something to that regard? Looking at medications, again, there's so many potential causes for weight loss. And in red here, I mentioned increased calorie, protein, and fluid need. That is just one of many potential causes of weight loss. So here's an example to illustrate this further. If a resident is grieving a loss and is exhibiting depression, thus providing additional calories and protein resolve the poor intake issue? Most likely not. Identifying the root cause and underlying issue early is key to preventing unplanned weight loss. Perhaps the correct intervention in this case is to refer this resident to social services to deal with the depression first. Once you can deal with the depression, and they're still not meeting their needs caloric wise and continue to lose weight, then perhaps adding oral nutrition supplements and any other food items is appropriate. So just again, something to think about. And moving on to assessments here. So a comprehensive nutrition assessment. Yes, dietitian should complete one, right? Whether that's every admit, readmit, significant changes, quarterlies, annuals, etc. Okay. However, it's not just your dietitian that can identify and document the different components that comprise of the nutrition assessment. So again, when I do chart audits, I look for information not just in the UDA titled nutrition assessment. I will look at everybody's documentation and to see if they all match, they all tie together, and that ultimately the goal is appropriate from every discipline. So what must be included in the nutrition assessment? It has to be completed for any residents identified at risk for unplanned weight loss and identified for compromised nutritional status. And some information that should be included, although this is not all inclusive, importantly, the general appearance. Okay, is the resident robust, thin, obese, cachectic? What's their cognitive status? What's their oral health or dexterity? Are they able to eat on their own? What type of assistance do they need? The height provides relevant information to his or her nutritional status. It must be obtain on admission and an annual. An annual does not mean you copy what was written from a year ago or stated by a family member. It really behooves the facility that we obtain our own height and weight upon admission. Weight, again, usual indicator of nutritional status when used within the context of the resident's overall condition. And please, 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 somewhere in your policy, make a note, do not use hospital weight in lieu of facility weight. And then obviously follow the facility weight. And I could tell you how I could share so many different events that led to either an IJ or a G level tag on F692 because the facility decided not to follow their weight policy, and then they decided to use the hospital policy, and then 10 days post long-term care admission, there was now a 20-pound difference when the facility finally decided to obtain their own weight. And so then that was unplanned, unexplainable, and therefore the facility just took the tag. So please do not use hospital weight. I can't stress that enough. And then of course the interviews, if possible, involve the resident family members, key staff members such as dietitian, nursing, physician, pharmacist, etc. And then of course the food and fluid intake. Now this is where I also see where we could use more or use some improvement here, just in the hundreds and hundreds of charts that I audit throughout the month. We include the estimated needs, whether that's for protein, fluids, calories, but the missing component to that is we're failing to document as to whether those needs are being met based on current intake. And so therefore, it's really important that the CNAs, if they're the one collecting and documenting fluid and food intake, that they do so accurately before entering it in point-click care. That's the system that you guys use. And then fluid retention can cause short-term weight change. So it could be like a false weight loss. And then altered nutrient intake, absorption, and utilization. Labs is also important. And then pertinent medications review. For those that are dietitians on this call, although yes, it is out of our scope, we certainly still need to know the side effects of many medications, especially there's so many GLP-1 receptor agonists that's being used right now. Example of that is Ozempic and Wegovy, Victoza and Saxenda. We still see more metformin, which can also contribute to modest weight loss in some individuals. So just kind of, again, keep that in mind. And I'm going to move a little quicker here, Carmen. So I think we're down to about 6 minutes. Okay. Care planning, again, yes, it must be individualized and address the resident's specific nutritional concerns and preferences. It must address the following. So identify causes of impaired nutritional status, reflect the resident's personal goals and preferences, identify resident-specific interventions, establish time frame and parameters for monitoring, and update it as needed. Now, I just want to spend about a minute here. So there is a difference between a nutrition diagnosis and a medical diagnosis. Now, oftentimes than not, on chart audits, my finding shows that we're still using medical diagnosis for a nutrition care plan. So for example, Mrs. Smith had a significant weight loss due to diabetes, COPD, renal failure, blah, 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 blah. Well, does that have anything to do with nutrition diagnosis? So for example, what we should start seeing in a nutrition diagnosis is, instead of using diabetes, use terminology such as inconsistent carbohydrate intake. Lung cancer versus inadequate oral intake. CVA versus self-feeding difficulty. So the green is what we should be seeing in the nutrition care plan and not the medical diagnosis. And again, there's so many examples, and there's actually a resource out there that I can share with the nutrition diagnosis, and it's a couple of pages. Quickly here, sample nutrition care plan. So obviously you got the focus, the goals, the interventions. So for the focus, use the problem and etiology as the foundation. So, based on the comprehensive nutrition assessment and the findings, your care plan should read this way. Mr. Jones is at nutritional risk due to increased protein needs to meet the metabolic demands of healing stage 3 pressure or ulcer. Mr. Jones will meet 75% or greater of the estimated protein needs with diet and supplements through the next review. So that follows the focus. That makes sense. Interventions, actions that are directly resolving the etiology of the problem. So liquid protein supplement is ordered, milk at each meal, double portion of eggs at breakfast daily. Now, interventions, again, guys, it's not just oral nutritional supplements or food. So things to consider here, diet liberalization, weight-related interventions, environmental factors, disease process, functional factors, medications, food intake, maintaining fluid and electrolyte balance, etc. But again, we need to identify the root cause. So here are potential nutrition interventions. And we're not going to go through all of this because we're running out of time. But again, I think outside the box, not just adding and adding and adding more snacks and more foods and supplements and after supplements. And in the end of the day, none of those are effective because we haven't really identified the root cause. So here are some interventions I listed, although this is not all inclusive. Again, this is another one of those lists that I could probably add 50 or so more interventions. So when was the last time we used, allow residents more time to eat? Maybe they're slow. Maybe their lips are cracked. May apply lip balm. How about a dental consult because their dentures don't fit? How about as simple as adding just margarines with meals? How about having a robust fortified food program? How about inviting a family to eat with the residents? So, et cetera, et cetera, et cetera. I'm going to share the slides at the end of this meeting, so you guys will have this, but now breeze through the last few slides here. So ongoing monitoring of care plan interventions, obviously that is necessary. And monitoring should include interventions to determine if the resident goals and preferences are being met. Resident is observed, direct care staff interviews, record reviews specific to residents' factors, such as part of the comprehensive nutrition assessment, and then evaluate the care plan to determine if current interventions are being implemented and are effective. So it's really important. So survey prep, just a few things I've mentioned here. I'm sure there are others. A chart review. I would encourage your facility to create an audit tool. And I'll share a couple in the next slides here. And then if you're using point click care, under the MDS 3.0 report, I always have asked the dietitians to pull the census and condition report under section G, F140, because it lists the residents there with unplanned significant weight loss. And then I also asked authority to pull the resident care metric, CMS 802, criteria number 6 and 8, because then you'll know which residents exhibited excessive weight loss without prescribed weight loss program and dehydration. Creating a list of residents to ensure comprehensive nutrition assessment is up to date. So some examples would be, residents that are in tube feeding, hemodialysis, obviously weight loss, pressure ulcers, residents are maybe on adaptive feeding devices, thickened liquids, et cetera, et cetera, et cetera. I would also encourage the team to review the previous year's 2567 or SOD, Statement of Deficiency Report. Review any recent audits completed by a dietitian consultant if you have one. Review the facility weight policy, and then implement a consistent weekly NAR or WAR meeting. So nutrition at risk or weekly at risk meeting. That's really beneficial. Here's an example audit tool. So you pick resident samples and then you just kind of go across each criteria. And this is really a good way to audit the facility prior to survey. And I don't know if you guys can read that, but here's a more detailed, robust, and this is typically an audit. This is an audit I created for facilities that have already gotten either an IG, IJ, or a G tag, and they're completing a plan of correction. It's a very detailed audit tool. And then for investigative protocol, everybody has access to this. Just be sure the entire team that supports the weight system of your facility understand each component of the critical element pathway to the nutrition and hydration. So you guys have this tool accessible to everyone. And I would encourage the facility to complete this once or twice per year. And then last slide I have here, the key element of non-compliance. So to cite deficient practice, the surveyor must prove that the facility failed to do one or more of the following. So accurately and consistently assess the resident's nutritional status on admission as needed thereafter, identify resident nutritional risk and address the risk factors, identify, implement, monitor, and modify interventions, notify the physician in evaluating and managing causes of the resident's nutritional risk and impaired nutritional status, identify and apply relevant approaches to maintain acceptable nutrition and hydration status parameters, provide a therapeutic as ordered, and lastly, offer sufficient fluid intake to maintain proper hydration. So again, guys, sorry I kind of went through the last part pretty quickly, but we are out of time. So Carmen.
Thank you so much, Betty. We appreciate you joining us with that awesome expert regulatory review. And again, we're out of time. So thank you, everyone. If you have any questions, please feel free to email me. You all have my email, or Kaylee Hilliard as well. And we look forward to seeing you guys next month. Thank you.
Thank you, everyone.
Thank you.
Bye.